stage lung cancer. In terms of this is the survival published on the International Association of Lung Cancer Global Database. The things to highlight is as we go from top to the bottom is the early stage cancer. So the stage 1 are the cancer which is just localized to the lung. Subsequently, the size in the stage 2, the size goes above 5 centimeters. Subsequently, the stage 3 are the one which you start to get the lymph node involvement. As you can see, the stage 1 cancers have a 5-year survival of 90% as compared to stage 3C or unresectable cancers have a survival of around 12%. So it makes more sense that we identify the people early, we identify these people, and the treatment changes. So we hope that we get some diagnostic work of how do we actually do the lung cancer and what the management of lung cancer. Second most common cancer in the world is a leading cancer of cancer death. It is peak incidence around 65 to 75. We found that males are more than females, but the adenocarcinoma, which is now the most common cancer or most common subtype of lung cancer, is now more common in women. The men's incidence is declining, and the incidence in men and women is pretty much the same. Smoking by far is the most common etiological factor. There are found in 80 to 90% of the cases, and the difference in the gender means women are somewhat less susceptible. The effect of smoking still remain. The risk of smoking is about 2 times even as compared to non-smokers, even when you actually stop 30 years of smoking. Other important thing is asbestos, which has been known. Asbestos related, most likely associated with mesothelioma, but it is also associated with lung cancers as well. There's lots of gases, but less common. When you talk about lung cancer, we talk about 2 different subtypes. There's one is called a small cell lung cancer, which is 1/4 or 25%. Non-small cell is the predominant one, around 80%. When we talk about the non-small cell lung cancer, there's a 2 most common subtype. One is the squamous cell, which arises from the inside the lining of the airways. The difference and how we actually differentiate this tends to be a more central, and it is more near your airway, and it is very strongly associated with the smoking. Whereas the adenocarcinoma, which is now the predominant cancer, arises still common in smokers, but it is now also widely seen in non-smokers as well. Women found in more, and it is more at the periphery of the lung, not more central, and it is highly likely to travel outside. So this adenocarcinoma is most likely to present with somebody who has got a lung mass in the lung, and they present with the mass in the brain as well. So that is more likely to send out the cancer cells outside. The other rare subtypes are large cell, 10 to 15%, and they are usually quite rapidly growing. So we talk about one of the most common one, adenocarcinoma. One of the biggest problem is it can differentiate. There is something called as a bronchoalveolar carcinoma. If you find that there is more lining of the lung involvement, then you're probably looking at the more bronchoalveolar pattern. There are some rare subtype which I don't have to say, but well differentiated mucinous signet cell, but these are very, very rare subtypes of adenocarcinoma. Just a quick note on the large cell. Large cell could be also classified as large cell neuroendocrine, could be classed as basaloid, could be classified as lymphoepithelioma, could be classified as clear cell, large cell rhabdoid, basaloid carcinoma. They're all regarded as a variant of a large cell carcinoma. Neuroendocrine cancer is slightly different as compared to the other ones. They are the neuroendocrine, just meaning that most of the lumps or most of the cancers are not biochemically active. So neuroendocrine cancers are the one, in addition to the lump, they have activity biochemically as well. So they usually a staining on a slide is what can actually make a differentiation. It is quite important to differentiate because the pathology, the prognosis, etc., is actually very different. There are some other rare cancers, about less than 1%. They are spindle cell, giant cell. These are generally regarded as highly aggressive cancers, and they do not generally respond to the treatment. So what's the difference in the lung cancer? So the difference in lung cancer, it is not just important these days that we just talk about the lung cancer. We need to talk about the subtypes. We need to talk about the molecular, what's the cancer looks like. The prognosis of an adenocarcinoma can really differentiate between all this. So historically, 30 years ago, this was what the cancer would have said. It is an adenos, squamous, or large cell. 1987, we just said, look, oh, there is KRAS mutation, which does not respond to chemotherapy. So that was quite important to identify it early. 2004, we started to identify first target, which is called as EGFR. Subsequently to that one, we have got multiple targets, which has been identified. And I will explain that in the further slides. So what does that mean? It just means that if you identify a subset of cancer, which is, and the mechanism of how it actually grows, then you can actually give them the treatment, which is very specific. So the most common one is the epidermal growth factor. Then it actually, in a downstream pathway, helps to grow the cancer. Then you can actually, when you block the pathway, stop the cancer from growing, and these people do really well. There are other potential targets you can actually name it, and the list goes every 3 to 4 months. You've got your KRAS, ALK, HER2, BRAF, ROS, RED, NTRK, MET, etc. So there are multiple. The mutations are generally exclusive, except PI3CK and BRAF. EGFR mutation, you've got the EGFR and ALK mutations. So there's lots and lots of target now we can actually identify. But saying that one, these are not very common. They are seen only in 5%, HER2 mutation 2%, PI3CK 2%, ROS 1 to 2, RET 1 to 2%, NTRK 0.5, BRAF 1 to 3, MAP kinase 1%. So these are not common, but if you identify them, these subset of people do really well. Now you've identified the molecular, you've got a cancer, you know what the molecular subtyping is, then you now define, okay, what's the stage of the cancer? In order to define the stage of the cancer, you need to identify how big the cancer is, whether there is any lymph node with it, or where else has the cancer traveled. So all these factors combined together makes a staging. And there are different classifications from different associations which define the staging of the cancer. What do you use? You normally have a clinical examination, you talk about the history, physical examination, you do some routine blood tests, chest x-ray, CT scan, PET scan is now considered as a standard in Australia for the staging of the cancer. Sometimes, even though the PET scan, you could do a biopsy just without the bronchoscopy, but in some situation you need to do a bronchoscopy, or you need to do further sampling to definitely stage the cancer. Broad classification, what we're talking is stage 1 and stage 2, and some cancers in stage 3. They have the best prognosis. They depend on the size, they depend upon how fit the person is, whether this person has any contraindication to any surgery. Sometimes after stage 2 or stage 3, we talk to these people about chemotherapies, that's just trying to treat the microscopic cancer disease. Now we talked about the stage, somebody who's got a T3, T4, or who has got a lymph node N2 or N3 disease. These people have unresectable disease. These people where surgery alone is not effective, they either have chemotherapy or chemoradiotherapy. Stage 4 is, as the name suggests, is the one where the cancer has obviously left the point of lung, and it is either seen in any of the vital organs such as liver, bones, brain, etc. How do you evaluate something, the lymph node, which is right in the middle? Sometimes you need to have these lymph nodes which can make a differentiation between a curative and non-curative treatment. So you need to do further testing which can identify. So some studies have shown that if you identify the 9 to 12 lymph nodes, the hazard ratio is 0.86. But however, the more the lymph nodes, the better. But however, 16 lymph nodes is considered as standard lymph nodes to evaluate. If you haven't found cancer in a 16 lymph node, it is highly unlikely the cancer is going to be there. CT scan, most common. The pooled study has said it has got around the sensitivity of around 51% and specificity of 86% in picking up this cancer. in terms of in terms of finding a lymph node, it can find about 61% sensitive and 79% specific. PET scan, this is the difference between a PET scan and a CT scan is the type of dye they actually use. So PET scan uses a sugar labeled dye. So sugar is actually labeled, or a glucose is labeled with a contrast. Once you inject this sugar labeled dye, any source of infection, inflammation, cancer will actually take the sugar towards it. And as you actually draw the sugar towards it, because of the high metabolic rate, because of the infection, inflammation, or cancer, you actually get to see any sites of metastasis. PET scan has got highly specificity, and it has become a standard of care for the staging. In terms of the standard of care now, CT and a PET scan, there is something called as a fusion, where you have a CT scan, you have a PET scan. PET scan just gives you the uptake, and then you actually fuse the images to figure out which anatomical location or the body parts will have the cancer. So PET CT is the standard, and that's probably seen, and that's probably available in the most tertiary centers in Australia. Other tests are standard. You're looking at how the patient looks like, blood pressure, you do the lung function test. Lung function test is usually quite important for the surgeons, because if you decide to operate on somebody, you need to make sure they have adequate lung function tests before and after. The bloods, which basically looking for signs of anemia, kidney function, liver function, and as I said before, the various imaging scans such as chest X-ray, CT, PET scans, and bronchoscopies if needed. Then you obtain a sample just to figure out under the microscope to figure out what the cancer looks like. Either you've done it a bronchoscopy, or you just put a needle with the CT scan. Then you look under the microscope and then figure out. It could be something from the lung, it could be liver, or it just could be a surgical specimen, etc. So one of the important things is these days is quite common to see somebody with a smallish lung mass, but they come out with single brain metastasis or a single spot in the brain, which has got its own consequences in terms of the people's work, people's employment, their people's life, the future prognosis, etc. So somebody who just present with a single brain metastasis before lung surgery, MRI has got a high detection rate of approximately 7% from pre-treatment to 12 months after surgery. Is pretty standard. Whereas in the later stages, it's about 7%, whereas if you look at stage 1 to 2, is about 4%. This is what looks like. This is how we actually define. So the T basically involves is how big is the size of the cancer in the lung. 1 centimeter, 2 centimeters, 3 centimeters, 5 centimeters, 7 centimeters, and that's how it actually defines. The N1, N0, N1, N2, N3 just basically defines how many lymph nodes are involved, or how many lymph nodes are suspected to be involved. N0 means no lymph nodes, N1 means 1 or 2 lymph nodes on the same side of the cancer, N2 and N2 is the lymph nodes on the other side of the lung, whereas N3 is a distant lymph nodes. So the stage of as you can see, the stage of the cancer increases as the lymph node burden increases. Whereas the M1 or a metastatic disease, you can have a stage 4 disease regardless. You could just have somebody with just a lymph nodes on the other side, or you can have a cancer which is spread all across the body. So it is now make more differentiation, because somebody who's got a small volume or just a few lymph nodes is going to do much better to somebody who's got cancer spread wide across. So this is what, when we practice lung cancer, this is what we talk about. So as you can see, it is quite important to identify people early, because you can offer them treatment. You can actually, if there's 80% or 90% 5 years survival, for somebody diagnosed with a stage 1 cancer as compared to stage 4, where the 5% survival is only less than 5%. So it makes more sense to identify these people early. And we are often quite asked when we see lung cancer, somebody who were to be diagnosed 6 months or 12 months in advance, and what the prognosis of it. So somebody who's stage 1, stage 2, early stage 3, we are offering them a curative treatment. To stage 3B or 4, where we're just offering them palliation. This is just to see what the size of the cancer, of how the staging, which is Tx, T0, T1, it is just defined based upon the size. T2 is also defined between the size, and how to differentiate between T2A and T2B is the size of the lung cancer. T3 is somewhere between 5 and 7. It is grown into one of the structures. It is grown into the lining of the lungs, etc. T4, when it is actually bigger than 7 centimeters, it can invade into the windpipe, voice box, food pipes, spinal canal, etc. Lymph node, as I said before, N0 is no lymph nodes. N1 is the lymph nodes within the lung, or lymph nodes where the airway join, which is right in the middle, or what we call is the hilum. N2 is on the same side. N3 is on the opposite side, just above the clavicle bone or on the top of the lung, etc. M1 basically just means metastasis, and it is where the cancer and how far the cancer has actually spread. And I said before, M1A, M1B, M1C is not, the reason for differentiation is for prognostication. It does not make a difference in how you actually treat them, but however, some M1A prognosis is much better as compared to M1C. So I talked about a small cell lung cancer in the beginning, which is a subtype of lung cancer, which used to be the most common cancer about 100 years ago, where this cancer was most commonly associated with smoking. This cancer was quite aggressive. This is one of those cancer-related emergencies that we have in oncology. Small cell lung cancer is staged slightly differently, called as the valve stages. You either actually call them a limited disease or an extensive disease. Once it leaves the same or one region of a lung, it is extensive. Whereas if it is limited to the half the lung, whether it's a lymph node, and they can just be incorporated into one radiotherapy field, it is called as limited. Anything beyond, it is called as the extensive disease. Lung cancer is quite common. These days, most common presentations are usually asymptomatic. Most people these days, we find lung cancer on somebody who presents for a knee replacement and went on to have a chest X-ray and found to have the lung lesion. Somebody had a pacemaker, had a chest X-ray, found a lung cancer. Somebody had scans for a visa immigration, found to have a lung cancer. It is quite unusual for these days to see a lot of symptomatic cancers with cough, weight loss, etc. Lung cancer is one of those cancers for us that can cause coughing with blood. It can compress on the important structures in the chest. It can cause a lot of swelling. It can actually cause compression, and it can actually be a life-threatening emergency. Other symptoms could be fever, malaise, nausea, cough, coughing up blood, host. People are completely asymptomatic. They do not have any signs for lung cancer. You can either have some lymph nodes, which you can palpate in the neck. Some people can't breathe. Some people have some changes in the nails. Or they could have fluid in the lung. So this is probably one of the most, or used to be the most common complication, where the cancer right in the middle of the chest is compressing on the big veins. It causes the face to go red, and there's a fullness. People can't breathe. You could have a pan-course cancer where they basically causes the pain in the shoulders. People just can't, and it actually affects and you can't open an eye. You lose a vocal cords, etc. If the cancer goes to the bone, it can cause some bony pain. If it goes to the brain, it can cause a stroke-like features, liver function test abnormalities. Adrenal gland is generally not the most common site. Normally is asymptomatic. Paraneoplastic syndrome is meaning the symptoms associated with the metastasis or the secondaries from the cancer. This could be a chemical related thing or a mass or a lump related thing. Some of the cancer secretes calcium. Some of the cancer secrete what we call as a PTHRP, which basically takes out the calcium from bone. And hence, when you measure these, and these might be the only symptom where these people have high calcium, and the calcium is being taken off from the bone, and these people presents with high calcium like symptoms. I have seen it in the past as well. People have been presenting to the GPs for years. They've been having kidney stones, bone pains. They've been classified as depression. They've been signs of altered mental status, tummy pains off and on. And these people have been either regarded as hypochondriacs, or these people have been regarded as non-specific and hyper. And if you treat them high calcium and you look for the cancer, then these people are sitting with the lung cancers itself as well. You also see something called as a SIADH, where basically you don't produce there's inappropriate antidiuretic hormones, the sodium is low, and in some cases causes brain swelling and death. Cushing syndrome, you get high level of steroids, and these people are the one who get the round face, or what we call as a moon face, muscle loss, etc. One of the rare neurological complications is called as a Lambert-Eaton, where you actually cause a weakness in the shoulders and the hip, as well as you actually loses the eye muscles as well. You can get the changes in the nails and arthritis affecting the joints. So what and where we should be worried about? We should be worried about somebody who's got suspicious finding on the chest X-ray, somebody who's under the age of 40 and come up with a coughing up blood, somebody who just can't breathe, somebody who has got a presence where the face is just flushed and face, you feel it's somebody who's been, we should consider an X-ray in somebody who just has a lot of chest infections, who's got changes in the nails, who's got changes, high platelets, or who's got some lymph nodes. We need to be thinking further ahead. In somebody who's been a smoker, somebody who has one of the following: cough, fatigue, shortness of breath, chest pain, weight loss, appetite loss, these are the ones that we need to start thinking about the cancer. Now, the big question is, how do we actually manage these cancers? We managed primarily by what type of cancer is it, how do we stage it, and the performance status is basically how much the patient can do. ECOG is the most common classification. There's another one called as Karnofsky. The patient performance status can go from 0, which is completely independent, asymptomatic, and unaffected by the cancer, to ECOG 3 or 4, which is basically spending more than 50 to 75% of the time in bed. Regardless of the diagnosis of lung cancer, we do encourage all smokers to stop. There is still benefit. Yes, their risk is always going to be higher than non-smokers, but even despite stopping the smoking, even after diagnosis of lung cancer, makes improvement in the lung function test. The management of lung cancer is very complex. It is actually beyond, and there are a lot of multiple factors, which is patients, their biology, etc. Generally speaking, stage 1 and stage 2 is surgery. Sometimes the lymph node sampling is done during the operation, which basically help us to define the prognosis and the staging of the cancer. Where this where chemotherapy can be used in combination with surgery. Something neoadjuvant is something which is prior to surgery. Adjuvant is following the surgery. When you're doing the neoadjuvant surgery, you're trying to shrink the cancer, so the surgeons finds that it is much easier to operate. Adjuvant is post-surgery, where you always believe in, from the oncology perspective, that there are some microscopic cancer cells which needs to be treated, and it gives them the better advantage. So chemotherapy is generally offered in the extensive disease. We generally these days, we have moved away from the chemotherapies, but there are a lot of other drugs like immunotherapy. Radiotherapy can help symptoms, mostly palliation, or earlier stages with stage 2 onwards, you got surgery followed by some chemotherapy or radiotherapy. As we can see, the adjuvant chemotherapy in the early stage, this is a retrospective analysis. The benefit, as you can actually see, the benefit in the stage 1 and the benefit of stage 1 in chemotherapy is actually quite small, whereas because death without chemotherapies increases, but also the survival due to chemotherapy increase. So the benefit is much more when you have a higher volume of disease. Stage 3, if you have a cancer which can be resected, you can either give them chemo followed by surgery, or you surgery followed by chemo. If it is unresectable cancer, then you can either do radiotherapy or you can do chemoradiotherapy. In some situation where the cancer is invading into the lung, then you can either do surgery or chemoradiotherapy. Stage 3 and stage 3, there is no role for surgery. It is chemoradiotherapy or systemic therapy with either chemotherapy, immunotherapy, or radiotherapy. Stage 4 lung cancer, as we can see, there is lots and lots of choices. Chemotherapy still remains a viable choice, but the most common treatment is chemotherapy with immune checkpoint inhibitors, which I'll talk about. And as we see, the treatment choices becomes more and more as we go into this. Chemotherapy from 1970s, chemotherapy is the standard. It is the 2000 onward, we had multiple targets and we continue to have more. Then you get the targeted therapy, checkpoint inhibitors are 2015 onwards, and they are the one that how we define the inhibitors. Checkpoint inhibitors are the one that basically modulating the immune system, and immune system is helping fighting the cancer. Immune therapy does not have anything directly against the cancer. It is just helping the immune system and the immune system finding the cancer. The immunotherapy checkpoint is a way these drugs basically are blocking the brakes of the immune system, which we can see the PD-PDL1 interaction, and these are the drugs which is actually blocking this interaction. There is nothing stopping the immune system running at a higher level, and hence this cancer, and hence we find that they are able to find the cancer and treat it. Another way of showing it, there are multiple drugs. We have about 5 and more drugs in which are available for lung cancer setting. Generally, these have a different side effects that we know of. The most common, these drugs have a side effect which can happen immediately, or they can even have it up to 6 months later. When we do suspect these side effects, generally mild one, we don't need treatment. The more severe ones needs they require steroids and a more specialist review. Small cell lung cancer, surgery in the limited stage is only an option in less than 5%. Chemotherapy is the standard of care. They are very chemosensitive cancer, and I said before, this is one of those situations in oncology where we do tend to offer them treatment upfront. Radiotherapy is mostly for palliation. Limited stage, either concurrent chemoradiotherapy or chemotherapy, or rarely surgery followed by chemotherapy. Extensive disease is a combination of chemotherapy and immune checkpoint inhibitors. Then there are some options for chemotherapies. Just a quick one on the older people, which is sub interest for me. The optimal treatment for the older patients remains unclear. There is no specific how do we treat the older patient with a limited disease, but most of the data, as previously said, the treatment in the older patient should not be very different, and the older people, just because of the age, do not fare badly, and hence they should be treated similarly. Prophylactic cranial radiation, in some situation it is quite valid, where in small cell lung cancer you prophylactically treat the brain. In terms of, there are consequences for this treatment because you're treating the whole brain. These people are at more high risk of cognitive damage. These cognitive can happen immediately, or it can happen up to 2 years after the treatment. Prognosis is highly dependent on the age and stage. 5-year survival, approximately 50% survive if they age between 15 and 39, but anything over 80 survive only 1 in 5 or just 5%. When diagnosed at the earliest stage, 88% survive, and later stage only 19%. Small cell lung cancer is very aggressive cancer. 10% of the population remain free of the disease, whereas 90% does succumb to the relapse in the small cell lung cancer. The median survival for limited stage is 16 to 24 months, 5-year survival around 14 months. We know we still have the new treatments, but however, they have not changed a significant amount in terms of the prognosis in the small cell. Extensive stage, anybody surviving long term is rare. Maximum survival is about 6 to 12 months time. And these are the few references. Happy to have any questions. Any questions for me?
Yeah.
A little bit of background noise there. Can you hear that, Divi?
Yes.
Go ahead if you had a question. Chloe?
Hey, my question was just in relation to the older patients. You mentioned that the treatment should be essentially the same, and I just wondered if there were like comorbidities present, such as dementia, if that changes that, you know, opinion about the treatment sort of still being the same.
Two questions. I mean, when we're dealing with the older people, especially 80 and over, we do tend to, I think there is now more data to do what we call as a functional assessment, not just looking at, okay, what, not just saying how much can you actually, can you walk the room, can you just walk from the clinic room to the waiting room, etc. But generally, what we talk is a comprehensive geriatric assessment. Secondly, there is data enough to suggest that treatment, that now we got more and more trials to suggest that the same treatment in a younger adult and the older adult tends to work similarly. In situation where you are dealing with the dementia, and dementia is quite a varied spectrum. You could go from somebody who has got a very minimal cognitive impairment, which does not affect their impairment, or somebody who's got very severe dementia and really dependent on the treatment. Somebody who's got a very severe dementia, I would be strongly, I think, you're more inclined towards a less aggressive treatment. You're more inclined towards more towards the supportive care, but that's based upon the severity as well.
How did that go, Zoe?
Yeah, that was perfect. Thank you.
Any other questions for Divi?
Hi, Divi. It's Peter Kaheny. Bit of a question and also an observation with, I think, one of your earlier slides with regards to the long-term impacts of smoking. I think it was 2 times that of a non-smoker some 30 years down the track.
Yes.
Insurers do charge smokers an additional premium. Of that. If they cease smoking for 12 months, they can apply for a review. Anna Gordon. Thanks, Anna.
So I didn't get the last bit. So the smokers charge
Yes.
premium.
So the insurers will remove the premium after 12 months of non-smoking.
Yeah.
So yeah, I guess obviously given the slide that you showed, could we be doing ourselves a disservice in terms of collecting not collecting enough premium, given those stats? I don't have the claims data to tell you either, but it's just
I mean, from the clinical aspect, the risk for smokers, even after stopping smoking, will always be higher. The risk, I don't know where the 12 months comes back, but their risk will never be similar to a non-smoker. It does drop. It does drop a few years later, but to 12 months, it is still as high. 12 months, it is better, but it is not. I'm not sure why the 12, but the risk for the smokers will always be higher as compared to somebody who's never smoked. They will always be more likely to be lung cancer or lung cancer related issue in the future too.
Many thanks for that.
Mark, I think you're muted.
Only been doing this for about 2.5 years and still forget. I was just going to let everybody know that the slides for today will be distributed. Also, with Divvy's permission, the recording for today will be made available for you to access as well. Any other questions? Comments, feedback? Divvy, you might have an early mark today. Obviously, as a consequence of today's presentation, your email address will be made available on the presentation as well. So we're now getting thank yous coming in from everyone. So I think I'll take that unless there are any last questions. To thank you, Divvy, being able to access your up-to-date information and insights into lung cancer has been really, really appreciative of everyone, as you can see from all the messages that are coming in. So it's been a highly informative session, and look forward to the next one.
Thanks, Mark. Thanks so much.
Thank you, everybody.